My name is Nicholas Torres, and I serve in the capacity of Executive Director of the network, TUFH, Towards Unity for Health. So I'd first like to welcome our panelists. So David Bohr, he is the Chief Academic Officer at Cambridge Health Alliance, which is affiliated with Harvard Medical School. Dr. Bohr previously served as CHA's Chief of Medicine for 21 years, during which he trained, mentored, and recruited hundreds of providers and current leaders. Dr. Bohr has made major contributions as a clinician, teacher, and administrative leader. He's also the Charles S. Davidson's Professor of Medicine at Harvard Medical School. He has dedicated his career in academic community improvement, co-founding the Cambridge AIDS Task Force, Cambridge Harvard Health of the City program, and the Institute for Community Health. Welcome, David.
Thank you.
Robert Woolard, Dr. Robert Woolard, who completed 2 terms as the head of the Department of Family Practice, Faculty of Medicine at the University of British Columbia. He has chaired senior committees, councils, and task force for the BCMA, CMA, and the CFPC. So welcome, Robert. Charles Bowen is a medical doctor specialized in public health from the University of Montreal, Canada, epidemiology, and education of health professionals. During his 30 years with the World Health Organization from 1972 to 2001, Charles developed worldwide human resources development projects in coordination with ministries of health and higher education, professional associations, and academic institutions. He was a regional advisor in the health and manpower development of the WHO Regional Office for the Western Pacific, Manila, and for Africa. At WHO headquarters in Geneva, he served as coordinator of the Program of Human Resources for Health and initiated several important policy initiatives. He is now an international consultant in health systems and personnel, and co-chairs a global consensus for social accountability of medical schools. So welcome, Charles.
Thank you.
Last, but definitely not least, we have Najat Huda, who is a professor of health professions of education at the Liaquat National Hospital Medical College. Najat Huda has worked endlessly in Pakistan for nearly 34 years, promoting community-oriented medical education and further enhancing the quality of medical and health professionals' education. She has worked in initial planning as a WHO coordinator on the project of initiation of community-oriented medical education in Pakistan, and worked with leaders such as Professor Zohair Zaman from Egypt and Bashir Haman from Sudan. Professor Huda is a founding member of the Women in Health Task Force and was chair of WHTA for 8 years. In her current position is a professor and director of health professions of education, Health Department of Healthcare at, again, the Liaquat National Hospital Medical College. So welcome.
Thank you. Well,
and so moving forward, to provide our participants a little context, I just wanted to remind everyone on the definition of social accountability, which is the capacity to respond to society's priority health needs and health system challenges to meet such needs. It emphasizes the potential of medical schools to partner with key stakeholders in the health sector and organize medical education in a way that has the greatest chances to yield most relevant outcomes and highest impact on people's health. The Global Consensus for Social Accountability of Medical Schools defines a socially accountable medical school as one that responds to current and future health needs and challenges in society, reorients its education, research, and service priorities accordingly, strengthens governance and partnerships and other stakeholders, and uses evaluation and accreditation to assess their performance and impact. So let's move to our panelists. And so we'd like each panelist to take 3 to 5 minutes to introduce yourselves, your organization, and your work related to social accountability. And we'll hand it over to David. David, would you like to start?
Sure. Thank you, Nick. First, a shout out for the network. I've known Bob and Najat and Charles for at least several decades. We meet annually at the network meeting, and we have conversations like this. When we first started, I don't think there was such thing as a laptop or an iPhone, and there certainly wasn't the chance to have this conversation more than once a year. So, Nick, thanks for bringing us together in this way. It's very cool. Nick introduced me. Let me just say a few words about Cambridge Health Alliance. This is a public institution in Massachusetts. It's primary care based. We have 2 secondary hospitals and a dozen health centers spread around 5 communities north of Boston, north of the Charles River. These communities have probably about 500,000 people. And we use the tertiary care hospitals for referrals, the ones that are Harvard affiliated, like the Mass General and the Beth Israel and the Brigham. We also run the health department for the city of Cambridge. So it's an integrated healthcare system that's primary care based. It's very unusual for the US. And it's the way healthcare is organized in much of the rest of the world. I've spent my entire career here. And I'd say the patients that we care for, a majority of them do not speak English as a first language. There are many refugees, large number of immigrants, and the population in general is quite indigent. So that's the community that I work in. And as I said, I've been here for my entire career. On the subject of social accountability, let me introduce 3 stories that I can tell later, but which talk about social accountability, not at the level of accreditation, but actually on the ground running. And I've learned through these examples several lessons. One is, if we're going to address the priority health needs of the nation or of society, of our communities, we first must be aware of what they are. And I can tell 2 stories about how I've developed an awareness of the communities. So one, thinking about the institution, Cambridge Health Alliance and Harvard Medical School, when health professionals and members of various governmental and community sectors are forced to talk to one another, to meet over time and to develop trusting relationships, and continuous relationships over time, they hear society's priority health needs. These emerge. And sometimes they're surprising. And I started an AIDS task force some 35 years ago, expecting that I would learn that the community really wanted to know about treatment. And it turned out that housing was their #1 issue. It was an interesting story, so I'd be happy to tell that story later. The second, about how do students develop deep, trusting, continuous relationships with patients and walk in their shoes? And how do they, and if they can do that, then they also can hear about the patient's priority health needs. Many of those needs fit under what we call now social determinants. And these are not generally addressed through traditional health services. So we have a clerkship here, what we call the Cambridge Integrated Clerkship, for 2nd-year Harvard medical students. And we have the students really walk in their patient's shoes for a full year's time. And I'd like to talk about that later. And then the third lesson is that I believe that the education of health professionals should include pedagogy about advocacy, teaching them what are the levers of power, and how does one use those to influence practice and policy. And we're in the midst of developing a Center for Health Equity, Education, and Advocacy here at Cambridge Health Alliance. So those are 3 stories we can come back to later. But my main lessons are, you have to be aware of society's priority health needs if we're going to respond to them. And we can teach not just about social determinants, but how to address them, and particularly through advocacy. I'll stop here for now.
Thanks so much, David. And let me turn it over to Charles to add his thoughts and any comments he may have had on your thoughts. So, Charles?
Well, thank you, Nick, for setting up that conversation, and bravo to the Network Towards Unity for Health to do that. Well, I had not the privilege of David to run a clinic and see patients every day, because my patients were institution, countries, political leaders, etc. As I spent 30 years in the World Health Organization in different part of the world, so I could at least see a very universal picture of what is going on. Of course, in the organization in which I worked for so long, of course, the main goal was to provide health for everyone. It was even called Health for All by the year 2000. And now it's called the Universal Health Coverage. And so we in my particular area, which was educational or health professional, the question was, are we contributing to that general aim to provide health for everyone in the nation? And of course, we certainly would improve the curriculum of health professional and advise leaders and teachers, etc. But very soon we noticed that even if we had done a good job in reorientating the medical education or the educational health professionals, we would not be totally sure that they would practice what they have been taught, because they have to be, of course, hired by several potential users. And so we were very soon confronted with the idea that it is important for us to ensure that we can have good linkages with not only the producer of the health manpower, but also of the users, which means, of course, the government, the private institution, and all the ones that are responsible for organizing healthcare. So the idea of Towards Unity for Health emerged from that sort of weakness that we could not do all the things by ourselves, even if we are, a very well regarded university or academic institution. So now I think the challenges indeed for us is to, as David said, is to know which are the needs. And of course, we're not thinking about medical needs, we're talking about healthcare needs, and health in all dimension of political, environmental, cultural, social, economical. And so it is I think a tall order if we consider how we can mobilize the different stakeholders over those values. Now, it is true that to be socially accountable, you have to have allies, because actually social comes from a Latin word, socius, which means an ally. So we got to work with others. And that is not an easy task, because everyone can be a political leader in a health authority or work in the pension scheme, what have you. You may have your own ambitions, your own goal, your own objective. So if you have to work with others, well, obviously you have to give up some of your prerogative of your own institution, organization, to protect the common good. So that is to me a very important issue, is the partnership that we can create with the local community, with the different stakeholders in the territory, and then of course to the political leadership, because at the end of the day, there needs to be some incentives to not be stuck in one's own territory, but to share with others. So I thought that what is very important also is to make sure that we have a common understanding of the words we are using, because many people that I have seen in my career worthwhile in different positions, they're all saying, of course, we are serving society the best we can. But are they accountable? And accountability is, you're accountable when you have to demonstrate that what you have publicly committed to, you're doing. And so accountable by definition is to go outside of your usual realm, your usual domain of your own institution. So let's make sure that we have a common understanding when we say accountability. If I produce good doctors, health professionals, am I, as a school, held accountable in the places where those people will practice? We may say, no, that's not my job. That is the government, that is the private agencies hiring them. We are saying, well, it's a little bit part of our job as well, because we can invite people, encourage people, show models, and be role models on how to serve. in the places where are more needed. So social accountability is that. It is to say, that's me, but I've got the responsibility outside of the realm of my own institution. And hopefully, all those ideas are now having some visibility worthwhile, which means organizations that are promoting the concept means a number of, I would say, challenges and also opportunities. And I guess we will have the chance to talk about opportunities and the challenges in the course of our conversation. Thank you.
Thanks so much, Charles. And I'll turn it over to Bob. And Bob, I just wanted to make you aware of one of the questions. So if you integrate that into maybe some of your comments and Shu was curious about in what ways are you making students aware?
Yes, I've actually read that, which is a very wonderful question, Anshu, because Anshu is asking if I think he highlights or she highlights the issue that I would like to deal with, which is the issue of scale. And the essence of the question, as I would understand it, is that since the majority of textbooks that his students or her students in India have to attach to and perforce the internet, primarily in the English-speaking and often high-income world, how do you translate that kind of knowledge into the real-life situation of a lower-income, middle-income country? And that introduces to me the issue of scale, because so if we're going to be socially accountable in the way that Charles has just outlined it, it goes all the way from our daily life and the patients that are in front of us to embrace the team and the neighborhood in which we work, to embrace the region and the health system in which we're embedded, to embrace the nation and all of the credentialing and other aspects of both medical education and medical practice exist. And then, of course, in the wonderful world of Towards Unity for Health, the international community, how do we, in fact, learn one from the other? So I just want to very quickly give a little bit of the Canada story in that, and the small part that I've played in that. If we think about that relationships that Charles alluded to, that David demonstrated so well in Cambridge, as I say, we can see them as a nested hierarchy of relationships that go all the way up to humanity. And one of the challenges has always been, and Charles knows this well, is that at the global level, we can make very wonderful agreements, rhetorical statements, etc., but that doesn't necessarily cascade down to the lived life of the patients in front of us and the neighborhoods in which we work. It gives a beacon, and I thank Charles because he has been a key architect in advancing social accountability in Canada, and I well remember his image of the beacon as the idea towards which we work. But Anshu raises the question, okay, that's fine. I can see the lighthouse, I can see over there, but how do I get ashore? And how do I bring my students ashore into this world of social accountability? Well, one thing we did in Canada at the turn of the century, in conjunction with Health Canada, which is the national body and national governmental body associated with the health system, was to develop a white paper. Basically a roadmap of how the medical schools can and should relate to the needs of the population. And that has, over the last 20 years, had some guiding mechanism, has been somewhat of a beacon. But today's talk, I think, is partly or somewhat focused on the role of accreditation in advancing that, because it's a very powerful lever. We have 17 medical schools in Canada. They all must be accredited. And over the 20 years, and I had a small part to play with this as I chaired the accreditation system for the medical schools in Canada, we've shifted to a place where, in fact, the very first standard in our accreditation, now increasingly infamous standard 1.1.1, is absolutely focused on social accountability and describes the activities and responsibilities of each of the medical schools to actually bring forth social accountability within the DNA of the school. And we can talk about that a little bit later. Translating that into action, I had the privilege, as mentioned in, and I apologize for the acronym spewing bio that Nick read about me, and I'm not going to describe all those acronyms, other than to say I had the privilege of being the head of Department of Family Practice here in British Columbia, and during that established particular foci on Aboriginal health, on inner city medicine, on palliative care, welcomed the School of Midwifery into the faculty, for which I was officially censored by the Medical Association, but that's another story, and elder care. So, taking the department and to some extent the university into those areas where we were clearly deficient in serving and being accountable to the populations. So those are different scales at which I've had the privilege to work, and which I think are important. And I think as we turn towards Darwin and the meeting of Towards Unity for Health, as we turn towards what I think Towards Unity for Health is becoming, it can become the venue, the place in which we weave together, as Anshu asks us, from the very particular, how do we share our knowledge? How do we share our learning? How do we learn from patients? And the short answer is our students will teach us if we simply put them in a situation with the tools to actually listen. And my closing comment is reference to the Patna Academy of Health Sciences in Nepal, where in fact, and I've had a small part to play in its development, the students within 3 months, the first 3 months of medical school after direct entry from high school, go and live in the community to listen, not to carry forward wonderful services, but to listen to the community. And that's woven through the curriculum over the next 6 years to the place where they teach us about what the community that we're accountable to. Thank you.
Thanks so much, Bob. Nijat?
I just would like to add where Bob, probably Bob and Charles Ford mentioned, is that I belong to a developing country. In developing country, there's a lot of rhetoric. I mean, we will do this and we'll do that. But at the end of the day, what happens is that after years of my experience, and I'm sure Charles and Bob would agree with it, we don't see much impact on population health. We do not see that the lives of the people have changed much, but we see a lot of talk going on that we're doing this and this will happen, but it doesn't happen. And the other area that, social accountability, I think the key point is the alignment, and I think traditionally we have been very possessive about medical school being an elitist school, an elitist community, and we do not tend to, forge relationship or partnership with community. It's some sort of running down it's a psychological, I think that's my observation, and many people have agreed with me. So there is lack of, we coming out of the medical schools and forging relationships. So I think this is one of the areas that we need to work very hard as to how to align the other, the stakeholders. And I think that's a huge challenge that, I face all the time. Basically, I'm more of an advocate than I can say my success story in social accountability. I have promoted I go and lecture and I may be invited speaker and I talk about, how important it is to be socially responsive, how important it is to be accountable, and how physicians should be trained so that they are accountable to the society and they are absorbed where they are needed the most. But somehow the other, at the policy level, I see the same division or the compartmentalization that the health system is different and it's working separately, and medical education or health profession education, whatever you may say, are working separately. They think as they are two different separate entities. And till today, I face the same issue, and I work on the same on this seems like endlessly working on and trying to how to forge this relationship between health system and medical education. So I think this is a very great challenge if you're working in a developing country, and to although the biggest need is in these, I mean, like my Pakistan is about nearly 200 million population, and the health indices are not so very rosy, I mean, appealing, very poor health indices. But then still, we do not see that concern as how to, how can we align with other stakeholders? How can health system and medical schools can come together and bring about improvement in population health? So I think this is been I look at it as a challenge for me, and I look at it as a great challenge even for other developing nations, because I read a lot and I find that this is a very common, area that needs to be worked on. The other is about the accreditation system, the accreditation that I think Bob mentioned. I just want to say, like in India as well, in Pakistan, we both have very traditional, we do have accreditation in place. I mean, there is a body that is known as the Pakistan Medical and Dental Council. In India, there is Medical Council of India. So we do have, but then if you, I mean, their role has been very, very different. It's more like you have more on the process. They're more, I mean, if you have how many rooms you have and how many lecture halls you have and, how many faculty members you have, it's more on that rather than what, how can you transfer this knowledge and can improve the health of the population. So I think we really have to think through, and we have to think, and somehow or the other we have to evolve strategies and how to move forward and how to make this really happen. So I think my job becomes very tough, and I work very closely with, because my institution does have a department of family medicine, and we have qualified people for that, and that's a blessing. And we have outreach centers, so we work. Um, I sort of work closely with, because I'm being on the education committee, so I work sort of bring in, I sort of forcefully do that, bring in family medicine and try to get them engaged into teaching, and then taking them out to the outreach centers and getting them involved in, and getting them, to write about it and do some small research maybe, so that students get at least interested and they can pursue a career, in their life. So I think these are the challenges that I think I face, and I'm sure that many would share this at the same time.
Thank you so much, Najat. And so as we move to the second question, which is how can accreditation criteria and standards be used to advance social accountability practices? I think we'd probably want to integrate that question with some of the comments. So we have Alejandro from Colombia is like, what's some most effective strategy to which you have managed to involve the community in health programs? I think there's a comment from Jill, which basically says advocacy and accountability require a blend of leadership and humility that puts listening and collaboration in the center. So I think part of the question is like, how do we not only use these standards and criteria to motivate institutions to change, but also how do we involve the community in that process? So it's a collaboration. So just put that out there to see who would like to comment.
Well, maybe something in line with that, I think, is as a little anecdote that may help us to understand maybe the underlying problems. I know a number of medical schools that have been models in the way they understand the needs of the people and they serve them. And the reason why those schools were so exceptional was because of the leadership. We had a great dean, we had a great staff, and so there was extreme motivation to do things differently. And that may, in those schools that I now are remembering, that may have lasted for some time, till those motivated people left. And then even up to recently, I had a story of such a school that has gone totally backwards to the classical way of dealing with things, in silos, every department being different from others and caring for themselves, and the whole idea of partnership and of course social accountability could have disappeared very fast. So it's a fragile victory, and we have to be aware of that. And the response to that, I think, are two. One is social accountability is not a discipline, a technology, or a method. It's a way of looking at the world. And therefore, I think the leadership has to be trained on that. President of university, deans, etc. Most of them have to accept that maybe they don't understand the whole implication of the term. And so I think there is a real need of capacity building at the highest level. Second, success may be temporary, and one to consolidate the victory is to have a national authority saying this is the way to go to protect the citizen on our nation. And there is no better protection than accreditation. It has to be a political act saying we understand the health challenges. We see that most of the institutions have to improve their performance to help the nations to get healthcare to everyone. And so it should be a national recommendation, and it should become a law. Of course, the university will be consulted in manufacturing the standard in the processes. So with some distance and with 40 years of the network towards Unity for Health, I think it is important for us to think in terms of policy, national policy. It is good to exchange with people from different countries and different places annually and otherwise, but it's not enough to ensure sustainability of our work. We've got to move now from wonderful experience, and we'll continue to exchange certainly all those ideas, to move to the higher level and see how we can be advocates at policy making level, health authorities and higher education authorities, so that we can sell the ideas and make them very pragmatized by accountability and by accreditation of social accountability.
It's Bob. I wonder if I could build a little bit on both the chat box and what Charles has just said, and that's looking at the nature of the accreditation systems themselves, which is what we're attempting to do. At one level, one can look at the accreditation system as a guarantor of standards, et cetera, the way it's often done. And sadly, the general culture of accreditation is one of the auditors, people coming in with a checklist, counting how many fire extinguishers there are down from the dean's office and that kind of thing. They have evolved, and I think we need to help their evolution by engaging in them. As I say, I had the privilege of chairing the system in Canada for a number of years, and pushed with some limited success towards the idea that instead of being auditors, we might conceptualize the accreditation system as peer review, where ideas can be tested, where there are we can give to society some reassurance, but not a system that in fact keeps re-endorsing the status quo, whether it's related to research funding, whether it's related to the stature in a magazine's ranking of universities, et cetera, the kind of sad things that we often use, but rather looking more towards how well does that institution respond. So the phrase that I think is perhaps useful is to say that social accountability and particularly the role of accreditation related thereto should be a springboard for innovation, not an excuse for the status quo. And that kind of peer review, in which as a profession, we need to constantly challenge each other to be the best that we can be, to serve in the most appropriate way that we can serve. That's the, I think, attitude that we need to use as we redesign our accreditation systems.
Yeah, I agree with you entirely, Bob. I mean, the accreditation systems that ask to tick boxes to demonstrate that one is socially accountable, I think are not very effective. And it becomes just an exercise in ticking boxes. Every community is different, has different cultures and different standards of getting things done. And I think it's much better for the accreditation to ask the question, how do you demonstrate your social accountability? Then it prescribes ways to do that. And let me tell you a quick story about my own experience in this own little part of the world. And this, in a way, answers Jill Allison's question about making things local. In the mid-1980s, I was at a patient's home when he died of AIDS. It was a time when I'm not sure that there was the name for AIDS. There certainly wasn't a diagnostic test. We didn't know it was a virus at the time. And it was an epidemic, and it hit this area pretty hard. And after he died, I found myself on the telephone for a few hours trying to find a funeral home that would take his body. And the next morning, I was so incensed about both the discrimination and the fear on the part of these funeral homes, but also that I was spending my time doing this. But the next morning, I walked into the city manager's office, it's like the mayor of Cambridge, and I demanded that he allocate funds to hire a coordinator of social services for the city to address the AIDS epidemic. And he said to me very wisely, I don't just give money away. You need to create a constituency that will demand funding and demand action from the city council. I'll see that your constituency gets a hearing, and maybe they'll come up with something wiser than a social service coordinator. So I walked out kind of discouraged that I'm an infectious disease doctor. I wanted to try to address an epidemic patient one at a time, and I didn't feel as if my job was to be a community organizer. We put in an ad in the local newspaper and said the first meeting of the Cambridge AIDS Task Force would be on such and such a day. And I expected no one to show up. And it turned out the auditorium was completely filled. And I or my colleagues stood in front of the group and said, we're gathered here together to talk about how we as a community can address what seems to be an epidemic. And people started shouting immediately, who do you think you are, doctors, bringing the community together? This isn't about healthcare, it's about health. Someone said, no, it's about racism. This has to do with discrimination against Haitians who at that time were particularly stricken with HIV virus. Someone else said, no, it's about gay liberation, gay rights. Somebody else yelled, no, this is about legalizing marijuana, and so it went. And eventually we were able to gain a communal feeling about why we were there. And this task force, after several meetings, prioritized the following three priorities. One was housing. The second was workplace rules against discrimination. And the third was education about contagion, of which we knew nothing at the time. I thought the issue really was social services and starting a clinic. And I really learned from that the society's priorities were likely to be different from my own priorities. I couldn't guess what they were. And for that moment, for that community, the task force seemed to be a way for multiple sectors to interact. Somebody from that task force said, gee, I know of a building that's been condemned, and I'm a builder, and I would be willing to, somebody could come up with money to build a hospice. And someone else said, well, I'm from the city planning department, housing department. We could give people with HIV priority for city housing. And someone else said, well, we ought to start a nonprofit and be able to generate grant funding. And so it went. And the resources in that community, in the pentagram, as Charles had defined it, from the health facilities and from the community and from policymakers and administrators, all got together and figured out how to address societal needs. That worked for that community. It may not work for another community, and there may be other ways to get the community voice together. So accreditation ought to be very general, not specific ways to learn about the public's needs and to address them, but to demand that at least the institutions keep an ear open and feel as if they really have a social responsibility.
Nijat, do you have anything else you want to add to the conversation?
Yeah, I think I would just like to add that what Charles mentioned in the beginning was about leadership. And I think that is the priority, because you need a different state of mind to lead such institutions where you think that the population health is important, and that's where we need to work at, and that's where students or graduates need to go there and improve health. So I think leadership is very important. I myself have the experience of working in an institution previously, where and then he was my mentor as well, that he was totally convinced, and it was in 1990s, he was convinced that the medical school has to be different rather than the traditional schools, and has to go out of the boundary and go to the community and work with the community, find out what they want and respond to their needs accordingly. So I have seen a model emerging in the 1990s, but I don't see such models emerging now, despite we have so much, more data, more evidence. But this is my sad point. I think in 1990s we progressed more towards, community needs, priority health needs, and how to work on that. But now after that, I feel that it's more like, having a model based on integration or being an education myself. I'm not against that. But we've gone into the academics of things as to how we can have an integrated model, and where students will be trained and how we can develop this longitudinally. And so I think we do need to look accreditation. I agree that we have to work with those countries where there already exists a body. We have to work with them, and we have to come out with a solution as how to sort of build in the concept of social accountability. So unless we work with those accreditation agencies, it will be very, very different, very difficult and challenging for institutions to do anything, innovative in this regard.
Thanks, Najat. So I think we have time for one last question, and I wanted to frame it of this idea of healthcare professionals. And I think there's a lot of conversations is how do you get the community and the health and related healthcare professionals to be more active, both in the sense of going where they're most needed, but also being advocates of promoting social accountability. And I want to preface it with the idea that healthcare professionals could be a community health worker, a midwife, I forgot what you call them in Pakistan, Nijat, a nurse navigator.
Lady health worker. We have a very good program of lady health workers.
Lady health workers, correct. And so I guess there's a question, what are best practices? And I think David framed it very well, at least in Cambridge. Oftentimes it's more about community organizing and activating them. But in terms of when you look on a global scale, what are best practices to getting these healthcare professionals, including medical doctors, but all these other people that are participating in healthcare, active and advocates of social accountability? So would anybody like to start?
Can I I can just narrate if I have time, just a small experience. What we did in a medical school was the community that we had, that was adjacent to the school. We identified young women from the community and trained them as lady health workers. And, to serve the primary healthcare, unit, as well as to uplift the community health as well. So those women were sort of then, of course, employed and given some, and it became a source of employment as well. And they used to go to every household. So that means the medical school got involved in, getting those young women who wouldn't have had any source of employment, got them, trained them, identified them with, if they had such basic education, how they could be trained, and then they could be equipped to go to every household, and then being brought, when they could identify. And they used to go with medical students as well and medical faculty as well to households. So I think this became a kind, a kind of a model where you could involve community from, women from the community as, participating in improvement of health with a partnership with the medical school. So I think this was my very good experience in this regard. So it can be that medical school can open up and do things innovative in this way.
Nigat has given us a wonderful example. What I would say, stepping back and looking over the way in which folks distribute themselves, at least in Canada and I think in most countries around the world, two issues need to be intertwined in the curriculum, in the assessment process, in the selection process for folks into school. And that is, we must aim for folks that are both competent to provide services in rural area where backup may be limited, so they're both competent and confident. Because when those two come together, competence and confidence, people are more likely to be professionally comfortable going and staying in such an area. The second point I make, however, was the biggest determinant of whether someone goes into a rural and remote area is not the professional, it's their family. And it's the relationship between the family and the community. And that's where the community and the building of that relationship become absolutely central. The third thing I would say is in terms of international migration. One of the sad things that one observes is that one can create wonderfully competent, confident, and idealistic youth to go out into rural areas. But if they're not supported there, if they're not supported within the system to practice their ideals and their capacity to the best level, it's like a child with their nose pressed against the candy store window. It becomes soul destroying. You can't serve in the way that you want to serve. So why wouldn't you leave a rural area? So, and that's where, coming back full circle to the points Charles was making earlier, it's absolutely essential that the service delivery, the educational systems work hand in hand to develop a capacity for people to go to rural areas, to feel confident and competence, to stay there for part of their lives, but to recognize their family will be the one that determines whether or not they stay there.
I agree with you, Paul. 100% I agree with you. And the main thing is that the government has to invest. The investment part has to be in those areas. So unless the government sort of lifts those health services in rural areas or in semi-rural or semi-urban, unless the investment is all tilted towards the hospital. Even in it's only recent rhetoric. A lot of rhetoric is going on recently. I hope it's not rhetoric and it's, serious. So the government has to invest in areas. Unless the government invests and develop those areas, then only you'll have your medical graduates go to those areas and serve the population that, the underprivileged or the underserved population. So I think a lot of investment is required. Good schooling. I've done some work on this as well. Why do you go abroad and things like that? And the thing is schooling for their children, because, you need good facilities, you need good roads, you need good housing. You just don't want medical graduates or, physicians or whoever to go and just live in a very, proper place. They have to be. So I think a lot of factors are, and I agree with you, okay, we need to really change our own mindset. That policymakers have to change their mindset, not blame the students or the graduates who leave, for better.
David, do you want to take sort of some last comments or answer the questions?
I have so little experience with placing people in rural indigenous areas or rural areas to work with indigenous people. Our challenge is to get people to work in urban areas to take care of poor people. And that's easier because the families can still live fairly close. So, but the one thing I've noticed, getting back to something that Bob said about the challenge of families, when I was a medical student, first in my class, only 10% of the class were women, and approximately 0 of us were married. So now that's very, very different. And I wonder whether placing students in rural areas with families is more successful in this era when there are families to be placed as medical students. And does anyone have experience with that?
Well, I think David, we're gonna parking lot that question, just because we're close to out of time. And I wanted to thank all of our panelists. So thank you, David. Thank you, Robert. Thank you, Charles, and thank you, Najat, for taking your time, especially if you're early morning or late evening, and joining us for this. I wanted to thank all of our panelists.
Thank you for having us.
It's great to see you all.
Same here. Thank you.
Thank you, everyone.